Tetracycline antibiotics are a real cornerstone of our clinical toolkit. And among them, doxycycline really stands out, doesn't it? It has this broad utility and a pretty favorable pharmacokinetic profile. So today, we're going to break it all down, from its core principles and how it works, to its key applications, the critical risks, and of course, the growing challenge of resistance. So to really set the stage for our discussion, let's start with this quote from our source material. Our goal here is to take a really precise, evidence-based look at how we can use these vital medications both effectively and safely. We're going to move beyond just listing indications and really try to understand the why behind our clinical decisions. All right, here's our roadmap for this explainer. We're going to kick things off with the fundamental principles and advice. Then we'll walk through the key clinical uses and the right way to dose. After that, we'll tackle side effects and contraindications, and we'll wrap up by looking at the really critical issue of resistance. Okay, let's begin with the basics, the foundational advice that ensures these drugs are used safely and effectively. And that really starts with understanding how the drug actually works. Tetracyclines are bacteriostatic agents. What that means is they inhibit protein synthesis by reversibly binding to the 30S ribosomal subunit. This action prevents the attachment of aminoacyl tRNA to the ribosomal acceptor site. So this is where patient counseling becomes absolutely critical. Now, while oral doxycycline technically has better bioavailability on an empty stomach, it can cause some significant GI upset, so we often have to advise taking it with food. And this is huge. We must instruct patients to report any severe diarrhea immediately. Why? Because it can be a sign of Clostridio difficile-associated disease, which is a serious complication that needs quick intervention. Now let's get into the good stuff. We're going to examine the key indications where doxycycline is our go-to first-line therapy. Let's take a classic case, urogenital and rectal Chlamydia trachomatis infections. Doxycycline is a primary therapy here. And the really critical part? Significant clinical resistance hasn't really been described. Think about that. It makes it an exceptionally reliable agent for one of the most common bacterial STIs in the world. And its utility doesn't stop there. It's also a powerhouse for Lyme disease. For early localized disease and even most forms of early dissemination, oral doxycycline is just as effective as intravenous beta-lactams. But it comes with a much more favorable side effect profile. So that makes it the clear first-line agent, which simplifies treatment and really helps with patient adherence. Okay, so understanding the why is one thing. The precise execution is the next. Let's dig into dosing and the critical interactions that can really compromise efficacy or even safety. So this table highlights a really key principle in how we dose doxycycline. Notice anything? The adult dosage is a consistent 100 milligrams twice a day across these common indications. The main thing we change is the duration. It goes from a standard 7-day course for an uncomplicated chlamydia infection all the way up to a 30-day course for late Lyme disease. This reflects the complexity and persistence of the infection we're up against. There are two interactions you really have to be vigilant about. First, polyvalent cations. Think antacids, iron, or calcium supplements. These will actually chelate doxycycline in the gut, forming this insoluble complex that just tanks its absorption and bioavailability. Second, doxycycline can potentiate vitamin K antagonists like warfarin. This is likely because it messes with the gut flora that synthesize vitamin K. So you've got to monitor that INR closely to prevent bleeding. With all this therapeutic power comes the responsibility of managing potential adverse effects. So let's turn our attention to those now. This comparison is so clinically important. While doxycycline's photosensitivity is a well-known side effect, and it's manageable, minocycline carries a much higher risk of some really severe idiosyncratic reactions, like drug-induced lupus and autoimmune hepatitis. This distinct difference in their risk profiles is exactly why doxycycline is so frequently the preferred tetracycline for systemic therapy. So to manage these risks, we really have to focus on prevention. Hepatotoxicity is a known, though rare, complication. What's much more common and preventable is photosensitivity. We have to be explicit with patients. Counsel them to use broad-spectrum sunscreen, wear protective clothing, because the photoallergic rash it can cause can be really severe. All right, now we need to talk about the absolute deal breakers.
the hard and fast restrictions on when you can use tetracyclines.
This is a big one. It's an absolute contraindication in pregnancy. During the second and third trimesters, tetracyclines cross the placenta. They chelate calcium and they get deposited in the fetus's developing teeth and bones. This causes irreversible tooth discoloration and can inhibit skeletal development. Now, for lactation, the American Academy of Pediatrics does consider short-term use compatible with breastfeeding. And for the exact same reason, it's also contraindicated in children under 8 years old. Giving it during this critical period of tooth development carries a high risk of permanent intrinsic staining and enamel hypoplasia. And the key word there is permanent. The irreversible nature of this effect makes this a safety rule you just have to remember. Finally, let's address what is probably one of the biggest challenges we face in modern medicine, the persistent and evolving threat of antimicrobial resistance. This chart gives you a quick snapshot of the current landscape for some key gram-positive cocci. You can see resistance rates in Staphylococcus aureus and group A and B strep. They're still relatively low, but they are not zero. These figures represent a very real, tangible erosion of this drug's efficacy, and they absolutely underscore the urgent need for robust antimicrobial stewardship. We have to preserve this agent. And this statement really captures the heart of the issue. Resistance isn't some static problem. It's an active evolutionary battle. And that means our clinical vigilance, exercised through smart, judicious prescribing and formal stewardship programs, is our #1 defense. Okay, to wrap things up, let's just solidify the two most critical safety takeaways with a quick question. First up, what are the two populations in which doxycycline is absolutely contraindicated? That's exactly right. Use is contraindicated during the second and third trimesters of pregnancy and in children under the age of 8. And it's all because of that risk of permanent effects on teeth and bones from binding to calcium hydroxyapatite. All right, second question. What's that notable side effect of doxycycline that really requires specific, proactive counseling from us as clinicians? You got it, photosensitivity. It's a common side effect, but it's manageable if we do our part and proactively and clearly counsel our patients on the absolute importance of aggressive sun protection. So I'll end with this question for you to think about. Doxycycline is still an invaluable tool, but its future efficacy is definitely not guaranteed. It really depends entirely on our collective commitment to antimicrobial stewardship. How we answer this question in our daily practice, well, that's what will define the therapeutic landscape for years to come.